I am now honored to introduce our keynote speaker for this morning, Dr. Aryeh Shander. Dr. Shander is very, very well known in the field of bloodless medicine. He is currently the Emeritus Chair in the Department of Anesthesiology, Critical Care, Pain Management, and Hyperbaric Medicine, which I'm really happy about because that's my specialty also, at Englewood Hospital Medical Center in Englewood, New Jersey. He did his medical school training at University of Vermont and completed a residency in anesthesiology at Montefiore Medical Center in New York. He then completed a fellowship in critical care medicine, and he is board certified in 4 different specialties in internal medicine, critical care, anesthesiology, and hyperbaric medicine. The title of today's keynote talk is Bloodless Medicine Education, the Ultimate Game Changer. And I am now very honored to welcome Dr. Shander to start his talk.
Thank you. So thank you for the organizers. Thank you for, again, putting together this wonderful society that I'm privileged to be part of. And again, speaking now for, I don't know what number of years that we've had this, but it's always been very gratifying, not only to see the number of participants, but also my colleagues who, as already mentioned, are enthusiastic about this topic. So I was asked to give this particular lecture this morning as Bloodless, the Ultimate Game Changer. But as you could see from the overview, I was asked actually to look at the role of education in terms of the barriers to implementation of bloodless medicine and surgery, as well as some of the prejudices that we see. So I'll start off with something that already has been mentioned, which is the definitions and the terms that we use in bloodless medicine and surgery. And the reason I think that that's important is because language is very powerful. As you see, as I'll progress through my talk, the words that we use and the concepts that we try to get across, we sometimes actually fail in transmitting the best communication that will give us the best results. And one of the things that we see a lot with bloodless medicine and surgery patients is the fact that the language that we use actually creates not only barriers, but immediate prejudices among the House of Medicine. And I will again mention this and expand on that a little more as my talk proceeds. The role of education is important. There's something that we need to understand, that education is basically transmitting of content. But as already mentioned by Dr. Russo, the fact is that there's skills that also need to be learned. And the process of learning knowledge or gaining knowledge versus the process of obtaining skills may not be the same, and at times could actually be conflicting. So what we need is both. We need the transmission of a well-organized body of knowledge, and at the same time, we need some sort of level of apprenticeship to, again, improve or actually give skills of care to those who are taking care of bloodless medicine and surgery. But I think that the one core, and already mentioned, was the issue of our duty as clinicians. Note that this is not just the duty for physicians, but all of us who care for a patient are within the world of clinicians. And our duty needs to be re-emphasized because, again, it is not just a body of knowledge, but also the responsibilities that we have towards ourselves as well as the patient. So this is essentially my overview, and we'll move on to the next phase. So bloodless medicine essentially is a misnomer. Again, not like healthcare. We talk about healthcare, but in fact, we care for the sick. It's really sick care, if you will. The fact that we are striving towards health, or at times actually do preventative health, these are the things that, again, you could see from these misnomers, that we need to expand the language so that we can again transmit the best information. Although these become household terms, they may not transmit the right information. But then we move on to the definition of bloodless medicine and surgery, which is the improving a patient outcome, which is a positive statement with the use of clinical strategies for their medical and surgical care without the use of allogeneic blood products. It really should be components, but we put that in brackets. The last part is a negative statement. Again, another positive statement is that this is a multimodality approach. So we need to think in terms of this definition is what it is that we're transmitting to the House of Medicine with this definition, and more importantly, when patients who are bloodless patients interface with the medical community. And many of us have relied on the fact that patients for whom blood is not an option, which fall into this definition and category, have been addressed, if you will, or maybe not addressed, but certainly have been considered to be a religious organization. And we do put this as part of the religious organization. We define we define the not refusal, but the decline of use of blood components, as you could see, the allogeneic, as a religious term. Now, I think, again, that puts a barrier in many ways and does cause prejudice also in many ways. And this is what I think. Is it a religious matter or is it the patient's choice? And I think if we reverse everything and just put patients in the front and start thinking in terms of what patients' choices mean, the religious portion of it may be the driver, but ultimately when the patient comes into the House of Medicine and is included into any care, when they move into, again, healthcare, that allows them to have choices in terms of what they are going to accept and what it is that they're going to decline. And also within those realms of acceptance and decline, they may be sorting out different things so that they may accept one thing, but not, again, accept another or decline it. And that doesn't necessarily mean that there has to be logic per se in each one of those choices, but ultimately it is the patient's choice. And I think if there is one thing that we take away today is that the religious portion of this, meaning the reason why the patient is making a choice, is secondary to the fact that they do have the ability to make a choice no matter where they are worldwide. And here's some of what I think we should learn is who benefits from bloodless medicine and surgery. And we define that as patients for whom blood is not an option. And yes, there is a religious group, but again, this is a choice that they can make. Each individual makes a choice regardless of the fact that they belong to a specific community. The alloimmune, those patients, again, with underlying hemolytic anemias and others, that's not a choice anymore. This is, again, something that they can't accept because of the detrimental effects that it will have on their health. So again, these patients do accept allogeneic transfusion, but now they've become bloodless without a choice. And when blood is not available, these are, again, not an issue of choices, but they're also very limited in terms of defining when these patients become bloodless, because it's a very short period of time. If they survive, they can go to an area where they can get their best care, but at that point, blood may be available. Whether it's military operations or civilian injuries with prolonged evacuation is those. And again, that's not necessarily a choice issue. But when blood that is available is unsafe, and as an example, we're seeing sort of in a side view mirror, not in the rear view mirror, COVID-19. And here again, if COVID-19 was transmitted and caused disease due to transfusion, here again we have no choice rather than the first one, which is a patient's ability to choose whether their blood is something that they want to get or not. I just want to bring this to everyone's attention and that is that bloodless medicine surgery was recognized in 2001 after the New York disaster with the Twin Towers by the US military as ways of caring for those injured combatants who required significant transport times, but also at very high altitude and cold, which is open helicopter evacuation. So this was recognized already that there was a positive impact of caring for patients without blood that improved their outcome. So others have kept their eyes open on what it is that we in bloodless medicine and surgery do. And as you could see, a few organizations came together and took the protocols for bloodless medicine and surgery and adopted them for the military. And that was done actually rapidly, almost overnight. So the underbelly of discrimination is, again, when a patient is challenging what we do normally in medicine. And one of the concerns that many physicians have, rightfully or wrong, but it is a concern, is that if they do not use blood, it creates a liability for them if there's a negative outcome for the patient. What is interesting is if they do use blood and there is negative outcome, the concern is not there as much as it is for, again, caring for patients for whom blood is not an option. And in this particular article, both Gina Lowell Dixon tried to, again, reassure the individuals that this is not just a choice of the patient, but that the choice is part of their advance directive, so that care should proceed. I think this is somewhat of a pedestrian way of looking at this. I think that rather than looking at the implications of the legal and the authoritarian processes that are out there, that one should really be looking at the duty of the clinician rather than looking at the protection of the clinician from a patient who makes a rational and a choice that they are not only allowed but have the capability and the autonomy to exercise it. So I think, again, we could see in the literature that there are some issues that we need to address as part of our education. And you could see the subtitle here being the surgical and the ethical challenge, although they are not really looking at the ethical challenge here in the way I would address it. And we do have data. And one of the nice things that we see is this is transfusion-free management of gastrointestinal bleeding. This is an experience of a Bloodless Institute. And what we're starting to see is the burgeoning, if you will, data that's being published now in terms not necessarily just of success stories, but I think also in the terms of analyzing the process of what we're doing and really giving our clinicians the tools to address some of these challenging situations. And as you know, gastrointestinal bleeding is a major challenge in medical patients. And here you see that there is the different variables that they'll be looking at in terms of the number of patients. And this is not a large study, but again, I don't think it's a small study. And they just break down in terms of where these patients are from, what kind of patients they are, some of the comorbidity, and you could see the location of the bleeding. And also what they looked at is the mortality. And you could see that here, even the mortality, which was considered to be 100% for patients who have a hemoglobin less than 3 grams per deciliter, that is not the case here. We're looking at less than 50%. And this is an organized, well-established protocol for treating patients who are having upper and lower GI bleed, for whom blood is not an option within a Bloodless Institute in the United States. When we had started, and some of this you've already heard me talk about, we had some concerns. we are basically leaving what is considered by the House of Medicine to be the standard of care. The standard of care calls for transfusing patients when their hemoglobin is low, or when the PT is elevated, or INR, that they get plasma. And of course, platelet counts, whatever they are, is arbitrary, denotes the use of platelets. And here we are now caring for patients without any of the blood components. So are we experimenting in essence? Have we moving out the standard of care? Does that now constitute human experimentation? And if so, is that ethical to do? Because the last thing we want to do is to take advantage of a population of individuals who are making a choice that makes them vulnerable. And making them vulnerable means that, again, they're looking for anyone who would help them or care for them without the use of allogeneic products, blood products, as mentioned, or components. And the issue, of course, does this constitute an unethical experiment, meaning that this is a group of individuals who are vulnerable, meaning that they'll accept anything other than the blood, and therefore we could do anything to sort of help them. So that was one. And the other, of course, as you could see from number 4, if this is ethical, how do we challenge our colleagues' years of tradition yet remain respectful? So how do we recruit more individuals into this? Because at the time when we started this, there was no data to support a lot of what we're doing. It was mostly anecdotal. So we did get both IRB as well as Ethics Committee involved. And we also went to at the time, the senior advisor to the AMA on medical ethics, Professor Ken Kipnis, the late Professor Ken Kipnis, who actually coined the term that Jehovah's Witnesses are heretics in the cathedrals of medicine, because they're not only just challenging the standard of care, they're really challenging some of the ethical issues that we have to address within medicine. Now, well, how do you look at progress? Well, here's one where we're outside the standard of care. This is Christian Barnard. Some of you may know, or some of you may be too young to remember. This was the surgeon who dared the story of the first human-to-human heart transplant. So again, to do that is this human experimentation. We can identify the needs. We can identify the need of a heart transplant. We can identify the failure of someone's heart or any other organ. But before we have the fact that we're outside the standard of care, to make the leap into something which is new and has not been tried, very similar to what we did with patient blood management and what we've done with bloodless medicine surgery, which was the precursor to patient blood management. Here again, you could see that many problems to be answered. So you're starting off on the road that doesn't have all the answers. And the same thing happens with bloodless medicine and surgery. We do have success stories, but we also have failures. And part of this issue is that we need to learn from the failures to be able to, again, build our knowledge so that we again can transmit it to those who are going to care for patients, including also adding skills. And we work through a lot of problems when it comes to any new innovation that we have in medicine, as one example. And I just bring you Philip Blaisberg picture over here with Christian Barnard. The reason he was not the first to have a heart transplant, but he was actually the first to be discharged from the hospital. The others were not discharged from the hospital and actually perished. So the changes that we're expecting are not going to happen overnight. And it's going to be not only just a challenge, but of course that we're going to revel in the successes, but we can't expect that we're not going to have failures. And those failures really are the steps forward. And we have to be, again, very grateful for the courage of those patients who gave their lives in many ways to advance medicine. And we shan't forget the fact that many patients for whom blood is not an option, and many Jehovah's Witnesses, have perished while we were building our knowledge of bloodless medicine surgery, but also many have perished because of the prejudice that was invoked because of the quote unquote refusal or declining or making a choice that went against what the standard of care and what physicians had in mind that was life, quote unquote, saving. So we call it the unmet medical need. And what I think is very, very important is that you're going to treat patients for whom blood is not an option. So to deliver bloodless care, we need to know blood. And we need to start off with understanding what blood does, not necessarily transfusion, but what blood does. And then as we build on this knowledge, before we even get to the skills, we also need to know what does allogeneic blood and its components does. So again, knowledge and practice may not be the same thing here, and they're not, but we need to build our knowledge base by understanding, number one, blood, if we're going to do bloodless, and then understanding the actual activities and the work that allogeneic blood does. And this actually builds, if you will, confidence, as mentioned already before, in terms of knowledge. So here's knowledge in terms of possible reasons for red cell transfusion overuse. This came out of the Middle East and Israel, was published in 2017, looking at overall knowledge scores of physicians in a single institution about blood and red cell transfusion. So we're not even talking about plasma and the others. And you could see that the score is less than 50%, what we call not a passing grade by any means. And there's a distribution of knowledge, as you see from this particular graph. But the fact of the matter is that even those who use blood don't know much about it, meaning the allogeneic components, and yet we who are not going to be using blood with bloodless patients need to make sure that our knowledge is much higher than this so that we at least can build, if you will, our knowledge in the right direction based on this. And again, this just to show you that this is not something new. This was published in 1990 by Suzanne Salem-Schatz and others, looking at the influence of clinical knowledge, organizational context, and practice style on transfusion decision-making. This shows again that the amount of transfused blood components was inversely proportional to physician knowledge of transfusion medicine. So you could see that as we build more and more knowledge, we may end up being on the spectrum of those who transfuse least, but here we're talking about transfusing zero. But knowledge is important in terms of getting us to that, because we now understand what other things can be done other than just relying on what is considered to be the standard under these recommendations. And here you see other publications. Some of them are repeated, but the fact of the matter that this is an area of skill which is lacking, in addition, due to very lack of knowledge and a very confused practice for patients. And lastly, is looking at a blood transfusion, 1 unit too much or 1 unit too few, which strategy poses the smallest risk to the patient. And here, this is by the blood establishment. And here we are saying that the best transfusion strategy and optimal dosing for packed red cells are still missing in most indications. Sufficiently powered, prospective, randomized controlled clinical transfusion trials for packed red cells in most clinical settings are urgently needed to reduce ill-founded clinical decisions and to base transfusion strategies on clinical evidence and scientific study results. How is this not going to improve the knowledge of our bloodless clinicians? Of course it will, because you could see here from this particular description by the blood establishment that knowledge is lacking, yet practice goes on and can be, as we already know, harmful versus withholding and not even including transfusion as a therapy for patients, as what we do with bloodless, where that actually can improve outcome. So there's no formal training other than this particular symposium, which has been going on an annual basis. But let's go back to when we actually were starting to look at bloodless surgery and bloodless medicine as an organized way of delivering care. And of course, some of you may know Sharon Vernon and others who have been pioneers in terms of getting education together. And this particular publication, the American Journal of Nursing in 1997, is a reflection of the school, if you will, that taught bloodless surgery. And Are You Ready for Bloodless Surgery was the title of this article. Well, you're not going to be ready unless you get knowledge transferred and skills. And Sharon was very good and is very good in transmitting both information in a very organized fashion and also identifying the needed skill to deliver a positive outcome of bloodless medicine and surgery. Well, this has not survived Sharon and many of us, unfortunately. So this remains, if you will, one of the drivers left this particular Bloodless Medicine Society and these educational symposiums that are there as the only driver for education versus going to a specific location, which was a school, to get both your knowledge and skill. They're not the same, as already mentioned, but I think that that's something that I'd like to emphasize again and again, that the fact that if you don't have knowledge, it doesn't mean that you may not have the skills. However, having knowledge and the skill together, even though there are different channels, makes for the best way of clinicians delivering bloodless medicine and surgery. But what can we teach without being in a specific four walls classroom? Well, we can teach the principles of medical ethics. Depicted here are the pillars of autonomy, beneficence, malfeasance, and justice, and also teach the duty of the clinician. Unfortunately, most of the language that's out there in terms of the duties of the clinicians refers to the physician. But since we need a multidisciplinary approach to bloodless medicine and surgery, every time you'll see the word physician, please translate that to clinician. And again, there's also the responsibilities of the patient. So there is two sides of the coin. One is ours, which is built with, as you could see on this particular slide, dignity and honesty of those providing care, and then relying on the four pillars, although there are three more pillars, but these are the major pillars of medical ethics. I just want to reiterate and digress a little bit because we do have the time. Not much is new under the sun. And most of us think of medical ethics as being born not in Western medicine, if you will, in the United States, but a lot of these principles have been around, as you could see, for centuries. This was the Hammurabi Code from 1750 BC. The Code of Hammurabi, the king of Babylon, is the first ever recorded legislations or rule governing the practice of medicine. The code highlights the fact that physicians, clinicians, perform a service to the society treating ailments and sickness. Again, the healthcare paradigm. In return, physicians are paid money, but also were punished if the results of the surgery treatment ended up killing the patient. Well, I think we are a little different today, although some of this remains actually in practice in some countries, mostly some in the Middle East. And then there was the Hippocratic Oath, which came around at 450 BC. I will use treatments for the benefit of the ill in accordance with my ability, skill, and my judgment, knowledge, but that from which is to their harm or an injustice, I will keep them. First, do no harm. Now, most of you think that first do no harm came from actually the Hippocratic Oath, but actually this sentence or this concept came later in the 1800s in one lecture, which credited Hippocrates for this, but the lecture was the one that actually initiated this particular statement. And some of our Islam colleagues, this is from the 9th century. This is the Adab el-Tabib, the Ethics of the Physician, the first ever book dedicated to medical ethics. We're in the West, we're behind. Great and very paternalistic, but great importance of a physician, clinician's faith in God and personal health and hygiene, as well as his or her manner with his or her colleagues, nurses, and patients. Again, the multidisciplinary approach. Fees charged for rich patients should be enough to cover the expense of poor patients. Well, this is interesting because that's what we do in the United States many times, is we cost shift. Doctors should keep records. That's clinicians should keep records of patients' symptoms, treatments, and progress so that they may be reviewed by peers should the patient die under the care of that particular. Again, keep in mind what we talked about before. Failures will happen, and we need to be able to review them so that we can learn more. And this is 19th century. And last, Muhammad ibn Zakaria el-Razi, from 854 to 925, not a long life, but pretty long then. The doctor's aim is to do good even to our enemies, so much more to our friends. My profession forbids us to do harm to our kindred. God imposed on physicians the oath not to compose mortiferous remedies. So again, you're looking at maybe the physician or clinician in terms of guidance, and the guidance is all there in terms of being an advocate for the patient. And this goes back many, many years. So medical, this is not just Western medicine as already, but medical ethics codes are all over the world. You have the World Medical Association, the British Medical Association one, and the American Medical Association. And I think as we build education and knowledge, it's very important to us to understand the code of medical ethics. I use the AMA only because it's closer to me, but keep in mind that the AMA principles of medical ethics are no different than all the others I just showed you. So the practice of medicine and its embodiment in the clinical encounter between a patient and a clinician is fundamentally a moral activity. Again, keep that in mind. That's a very important statement that arises from the imperative to care for patients and to alleviate suffering, regardless of their choices. It doesn't say here anything about the choice of a patient, good or bad. It has to do with what the clinician's responsibility and duty is. The relationship with the patient and the clinician is based on trust, which gives rise to physicians' ethical responsibility or clinicians' responsibility to place patients' welfare above the clinician's own self-interest or obligations to others, to use sound medical judgment, knowledge, and on the patient's behalf, and to advocate for their patient's welfare. Keep in mind, this is the principle of medical ethics across the globe, not just in the United States. And these words don't have anything in terms of what the patient's choice is and whether we're stepping outside the standard of care. Regardless of what it is, it defines our fiduciary responsibility as clinicians to the patient. There are exceptions. The patient requests care that is beyond the physician's competence, the skill. This is the skill of the clinician or the scope of practice. Okay, that's not unreasonable. No one should be, not everybody, if you're an internist and you're asked to do brain surgery, you don't have that within your scope of practice. So that's not an unreasonable exception. It doesn't mean that care should stop. It just gives the clinician a understanding that there are limits on what they can actually deliver to patient. Is known to be scientifically invalid, has no medical indication, or cannot reasonably be expected to achieve the intended clinical benefit. Well, we've seen a lot of that during COVID-19, but keep in mind that we're trying to be as much evidence-based, but I also showed you that our practice of transfusion medicine is clearly not scientific, not necessarily invalid, but the medical indications are not clear because everything was around safety and not benefit. is incompatible with the physician's deeply held personal, religious, or moral beliefs in keeping with ethics guidance on the exercise of conscience. And again, keep in mind that's the clinician. So the example is abortion for a devoted Catholic. The ethical transfer of care needs to be carried out, not just denying the patient care, but finding someone who would do that. I want to bring you, again, because of time, to the last of the list of exceptions. The physician or clinician lacks the resources needed to provide safe, competent, respectful care for individual. Physicians may not decline to accept the patient for reasons that would constitute discrimination against a class or category of patient. Well, we've seen that time and time again in bloodless medicine and surgery patients. And yet it's been written for years now that this is unconscionable when it comes to medical ethics. Meeting the medical needs of the prospective patient could seriously compromise the physician's ability to provide care needed by his or her other patients. This is the issue of triage, which is a little more complex. And this again goes not the physician, but all clinicians. But we have a way of addressing that. But the greater the prospective patient's medical need, however, the stronger is the clinician's obligation to provide care in keeping with the professional obligations to promote access to care. So we started off with a slide I showed you, the legal concerns the clinicians have. But again, when you're looking at the medical or the house of medicine or the medical profession and the codes of ethics, they're all obligatory, if you will, and the fiduciary responsibility of every clinician is to care for a patient regardless of the choice, and also, again, a word against discrimination. So it brings us to the power of language, which is, Jehovah's Witness patients or bloodless patients refuse blood, they decline blood, they choose not to have blood. The answer is no, which is all negative. The problem with this is that we need to change our approach. And changing our approach from negative to positive is essential, because when we say to a clinician, we will not accept blood, what the clinicians many times hear is that you're not going to accept anything. And there is what you see, what the clinicians hear when I refuse or decline results in a disaster. And we've seen many and will see many disasters due to this language. So we need to find a way of delivering the positive message, which is we accept everything. However, in lieu of, say, blood components, we accept X, Y, and Z. And I have to credit Franz Walker from Austria for actually switching the declining language to an acceptance language. And we'll see how that is developed over the time, since they're just now starting to implement it. So in summary, definitions and terms, is it a choice? And I think that we need to move the religious issue to the back and really highlight the fact that every patient has a choice, regardless of their religion, regardless of their creed or any other reasons. The barriers and the prejudices we already demonstrated, they're unethical. And as clinicians, our responsibility is not first to the law, but first to the moral code. And let me just say this, it doesn't mean that we're not law-abiding citizens. And many times we can actually follow and abide by the law and still remain moral and ethical. But there are times when ethics or morals clash with the legal system, as we could see is happening today in the United States with this issue of Dobbs. And there have been other issues where the legal clashes with the moral. I think I've mentioned this before to people, that in the United States, slavery was legal, but it was never ethical. So the role of education, sadly, is minimal, but it is essential. And the education we need to define and see if we can go back to, again, the principles that we know from Sharon Vernon of setting not only in motion a well thought out curriculum, but making sure that that includes also learning the skills, and it's done in an organized fashion, just the way we're learning any other medical discipline. And as you saw in terms of as I use the example of a heart transplant, we're collecting more and more data, and that's our role and also duty to collect data on our patients who are bloodless, not just in terms of anecdote, but as I showed you in an organized fashion with one publication that I use as an example. And the duty of the clinician is the ultimate game changer in my mind, which encompasses everything, including the elimination of prejudice, elimination of barriers, insisting on knowing the skills and the right education. And if the future is right, the success of bloodless medicine and surgery will be in its demise. And what that means is that we will no longer need to have bloodless medicine or surgery as a specific service, if you will, that every bloodless medicine and surgery patient can enter into any hospital wherever they are across the globe and get the right care, because it will become standard, and therefore we don't need to allocate BMS or bloodless medicine and surgery as a separate track for patients. And I thank you for the privilege of your time.